Thank you for joining today's webinar, ACOs, Care Coordination and Process Improvement, sponsored by the Society for Health Systems Conference Committee. I'm David Brandt, and I will be moderating today's webinar. I have a few opening instructions before I turn the program over to our featured speakers, Julie Silver and Bill Schwent. During the presentation, all audience members will be muted. We will take questions near the end of the hour. If you have a question at any point during or after the presentation, you can type it into the questions box on your webinar interface. Please craft the wording of your question as clearly as possible for our presenters. At the end of the presentation, we'll read through as many questions as time allows. Both the PowerPoint and the recorded version of this presentation will be made available online at the webinars page of the SHS website. We will email you a link in the next 7 to 10 business days. And now I'll turn the presentation over to Julie and Bill, who will start off by introducing themselves.
Thanks, David. My name is Bill Schwent. I'm a process improvement leader at Children's Hospital, Colorado. And I just wanted to welcome everybody to the first pre-conference webinar for the 2013 Healthcare Systems Process Improvement Conference. This is really the first year that we've done a pre-conference webinar series, so we hope that all the attendees certainly find it valuable, and we also hope that it generates a little bit of excitement about the conference that's upcoming. So again, thanks for joining, and before I turn it over to Julie, who's our featured speaker for this webinar, I want to just provide a little bit of insight into the organization, what SHS really is, what we stand for, and a little bit about the upcoming conference. So SHS stands for Society for Health Systems. We are actually a, sorry, here we go. Having a little trouble with the slides. We're actually a subcommittee of the Institute for Industrial Engineers, which I'll get to in a minute. But just a little bit about what I'm going to briefly cover, a little bit about the system, conference overview featuring our keynote, featured speakers, pre-conference workshops, and then also a couple other things that you can expect from this year's conference. SHS was, I believe, the first society under Institute for Industrial Engineers. We're actually celebrating our 25th anniversary this year. But we're nearly 1,000 members strong, with the majority of us working in some type of PI role in a hospital or healthcare institution. Most of us are, what you call management engineers, operations excellence professionals, PI engineers, QI engineers, PI specialists, consultants, whatever you want to call us. We all really are after the same thing. Everybody's after improving processes in healthcare using proven methodologies, data analysis, and process improvement methods. Our conference is really our key thing that's really exciting for us every year, because it's our main chance to get together with a lot of our peers that are all trying to do the same thing in their organization and achieve the same outcomes in their respective organizations. One of the things that I personally like about SHS is the fact that you can get together each year and then also stay in touch throughout the year through our various tools on our website, and really talk with a lot of people who are doing maybe even similar projects as you, but maybe taking a different approach to their work. Many of our members, like I said, are in the PI role, but we also have several people that are in the clinical roles as well. We have several nurses, physicians, clinicians, several people who are either trained and educated in those roles and maybe are now working in a PI role, but also several that are more in the nursing role, and they might just do some PI work on the side when they get the chance. As I said, these webinars are really in preparation for our upcoming conference. SHS partners with HIMSS on a yearly basis, just more for the logistical purposes of our conference, but also because the topics tend to start to overlap a little bit. And you can see here listed on the slides that we do have several kind of cross-networking type events that we have with HIMSS every year. Essentially how it works, both in the last couple years at Orlando, last year in Vegas, and this coming year in New Orleans, SHS has our conference usually a couple days before HIMSS, and then you start to see a transition on that last day when a lot of the members start colliding and really getting together and talking about their different initiatives. So on to details about the upcoming conference. I'll start off just by mentioning who our two keynotes are. We have one on each day. Our Saturday keynote this year is Roger Gerard. He works for State of Care as a Chief Learning Officer and now Executive Business Partner. I think he's transitioned to the Executive Business Partner as he's started his own role as the owner of Sloan & Gerard Consulting. Most notably, Roger Gerard has co-authored a book called On the Mend, and it's about the state of care's lean journey over the past couple decades. So state of care is very well known for their lean efforts throughout healthcare. They always have a big presence at our conference, and we're very interested to hear both about the book that Dr. Gerard has co-authored, as well as his experiences in healthcare in general. He's very much considered kind of one of the pioneers of our type of work in healthcare. Our second keynote near the end of the conference on Sunday is Dr. Joseph Garisco. He is the System Chief of Emergency Services at Ochsner Health. And in addition to being a physician, he also has an engineering bachelor's degree, which is very neat for us to hear. We always love hearing from clinicians, especially physicians or hospital presidents that have that very system-type background, because they often put a great spin on the type of work they do, and are often able to get great results because they have a very well-balanced approach and see both sides of things. So he's notable for his process improvement work in their ED, centered around information system and patient flow initiatives. But we also hope to hear a lot about disaster management, because he was the System Chief of Emergency Services during the Hurricane Katrina event, and how he managed that is going to be certainly a very interesting piece of our conference this year. In addition to keynotes, we also highlight several speakers during the concurrent sessions, and we just call these people featured speakers. But these are noted due to either the relevant topics or abstracts that we've received. They could either be hot topics, things that are really popular throughout healthcare right now in the current environment, or speakers that have been very well received in the past that we know are going to deliver a great message and have a very well received concurrent session. The concurrent sessions are really kind of the lifeblood of the conference. We have about 60 hours devoted to these over the course of a couple days, and they're generally 1 hour. Sometimes they're up to 2 hours, but this is where everybody gets to pick, what track they want to go to and what they hope to really hear and kind of share their experiences throughout those sessions. So we'll get to a little bit more on those in a minute. Again, here, these are the tracks of the concurrent sessions. You can see a lot of the main topics that most of our departments are centered around, such as Lean Six Sigma or patient flow. One other piece I'd like to mention is the pre-conference workshops. So our conference technically starts on Friday with the workshops. The concurrent sessions run on Saturday and Sunday. Pre-conference workshops are traditionally anywhere from 4 to 8 hour sessions, where it's really more of a working session and much more interactive than the concurrent session. Groups tend to get involved in activities, especially in the lean shops, that coincide with the sessions, with the main focus points and the teaching points of those sessions. This year, more or less just by coincidence and really by what I guess proved to be the most outstanding abstract that we received, we really ended up with 2 tracks for these pre-conference workshops. We'll have a 4-hour session in the morning, 2 4-hour sessions in the morning. One will be focused on lean, one focused on management, and then the afternoon will be the same. And so the morning session is all about what you leave behind, mainly focused on sustainment, whereas the afternoon lean session is more focused on something that's a little bit more specific, so using lean and reducing surgery change over time. And again, we also have management sessions running concurrently. So the idea here is that you can either hit one or the other, or you can hit both management tracks, both lean tracks, whichever you choose. And again, during the registration process, you can select if you want to do the lean workshops or if you want to do the pre-conference workshops at all, versus just kind of foregoing those and showing up Friday night or Saturday morning for the concurrent sessions. And again, the final piece to mention is the poster sessions. So in addition to our keynotes, our pre-conference workshops, and our concurrent sessions, we will also have several people presenting posters of their projects, or maybe vendors. A lot of times vendors tend to get involved here as well. I know we usually have Simulate and several other people that are presenting their products at this point. So this is really a great opportunity to go and view the posters and speak with the people who created those, because it gives you a nice time to have more one-on-one conversations with other people about their projects, and also to share ideas. This year is a special year for us because it's our 25th anniversary of SHS. We'll be having a celebration dinner on Saturday night which is something we don't normally do, but I think this is going to be another great opportunity to network with various people. We're going to honor and recognize several people that have been vital to the organization over the past 25 years, either those that really helped it get off the ground all the way to helping it grow to where it is today, and still those people who are very active and have been with the organization for a long time. At this dinner, we will also be presenting our winners of the student paper competition, the case studies, as well as the poster competition winners. So, what to expect from the conference in general? Really, the networking opportunities at this conferences are endless. We have table topics at both of our lunches this year, which is something a little bit new, but should be very opportunistic for anybody who is attending and wanting to talk about very specific things. We'll also have several networking events in the evenings, several designated times for networking throughout the day, and during those times you can also go in and look at the poster presentations as well. And all that's for the pre-conference workshops to be a very good networking opportunity in themselves, just because it's such a more, I guess, intimate and smaller environment where you really get to know people in an extended period of time. It's a great opportunity to reconnect with other peers who are working in a similar type role as yourself. And again, personally, this is one of the big reasons why I like SHS a lot. You have other organizations such as ASQ and different larger groups who might have healthcare sections, but don't really have a dedicated forum where only healthcare presentations are given. And I think that makes us kind of unique. You go to a conference or even just start talking with people outside of the conference, and you're really in a pool of people who are all trying to do the same type of work for their organization. And I think it's just a great way to share ideas and get new ideas from different people. Registration information is not open yet, but it will be soon. And you can find out more about the conference at shsconference.org. So you can click on the registration tab and keep an eye on that for whenever that opens up. We will have discounted rates available for students as well as corporations and hospitals. I think if you have 2 or 4 or more people coming from the same organization, you get $50 or $100 off registration. And since we do partner with HIMSS, we usually use them for our lodging, but hotel accommodations can be made through that website. But again, all this information can be found at shsconference.org, and it's pretty straightforward from the website. So with that, the final thing I'll say is that even just for attending this webinar, in the email that IIE will send out in the upcoming days, you will receive a small discount off your registration if you choose to attend, just if you use the link or the passcode that is sent out to you in the next few days. So with that, my plug for the conference is done, and I'm going to go ahead and turn it over to Julie, our featured speaker for the day. Julie, take it away.
All right, thank you, Bill, and thanks everyone for having me today. My name is Julie Silver, and I'm an administrative resident right now at the Greater Baltimore Medical Center outside of Baltimore. And I got my industrial engineering degree from the University of Missouri, and then went on to get my Master's of Health Administration at Johns Hopkins University. So today I want to talk to you about how the Greater Baltimore Medical Center is working to improve the care coordination process due to our ACO formation. So just a little bit of background before we get started. The Greater Baltimore Medical Center, GBMC, is a 281 licensed bed hospital. We are, in fact, a standalone community center with major competitors in the region. As you can see, there's Johns Hopkins, the University of Maryland, Sinai, and MedStar. As you know, the healthcare landscape these days, there's increasing competition, lots of financial constraints, and we're always facing the inevitable potential payment system changes. So what we wanted to focus on at GBMC was how can we actually create value? Well, our CEO, Dr. Chassar, wants us to focus on patient-centered care. So moving forward, so we can deal with these healthcare landscape issues, we really want to focus on the patient. We want to do what's best for our patient, what's best for the community of Baltimore. What we did is we chartered the Greater Baltimore Health Alliance, GBHA, in 2011 in order to integrate the delivery of both the employed and community-based clinical services. And what this is a network of approximately 400 providers with the goal of improving the trifecta, improving access, maximizing quality, while reducing the cost of care. GBHA was actually accepted as an accountable care organization through the Medicare Shared Savings Program this July. And for those of you not in healthcare, an accountable care organization, to sum it up, are the physicians, they're assigned Medicare beneficiaries, and these physicians are tasked with reducing the spend of these Medicare beneficiaries during the reporting period while maintaining or improving the quality of care. So in order to achieve this, we at GBMC realized, well, we need to improve upon our current care coordination process. And what care coordination is really is additional services. In addition to patients going to see the doctor, we are providing these extra resources for the patients to help them manage their diabetes or hypertension, to remind them you have appointments coming up or you need to do certain medications at home. So that's what I mean when I talk about care coordination. So our current care coordination challenge, we actually had care coordination before developing the ACO, but there's many current challenges that we need to improve upon in the future. For example, there is a lack of information flow between the primary care providers, the specialty physicians, the hospitalists, and the care coordinators. So what I mean by this is there's really no central repository. So if a specialty physician wants to know the background of a patient, there's no place for the specialty physician to go into the computer and look up what labs or diagnostics did this patient have at their primary care provider, which this inevitably leads to redundant testing. If the primary care provider already did a certain lab, a CBC one day, and the patient goes to the specialty physician the next day, well, since the specialty physician can't see that lab, they might order it again. So if the patient doesn't like it, and also from an ACO perspective, this is increasing our costs. Another challenge that we currently have with the care coordinator is their workflow. It's all paper-based. It's extremely cumbersome and inefficient. They are writing on paper all of their patient notes, and then they're having to either type it in to the system or having to scan it in. And obviously that takes a lot of time. They're burdened, and these are nurses that are care coordinators, so they're burdened with a lot of non-clinical tasks. One of our other workflow issues is there's no standard way across the GBMC outpatient facilities to specifically target which patients will need care coordination services. So for example, one practice might be specifically targeting mainly diabetic patients, while another practice may be targeting patients with a high BMI. Basically, it's not standard, and so we want to improve upon this in the future. So why now? Why do we need to improve upon our care coordination process right now? Well, we have to report statistics to Medicare in December 13 about our spend and also about our quality measures. So we want to make sure that we are improving by then, but we also want to make sure to monitor it until December 2013 to make sure we're on the right track. So we want to, until then, we want to lean out the care coordination process. We want to reduce the rework that I talked about with both the clinical testing, the redundant labs, but also the non-clinical duties, such as the scanning. We also want to ensure that more patients are able to get in with a care coordinator. Maybe we can optimize the care coordinator's time so that diabetics, hypertensive patients, and BMI patients can see them. So what GBMC has done is we've developed a strategy that leverages technologies to redesign the workflow of the care coordinator. So I'll talk about 3 new technologies today that we've implemented to streamline the care coordination process. The first one I'll talk about is the Health Information Exchange, or HIE. This program will allow providers to view a pretty basic medical record. They'll be able to see the discharge summary from the hospital, labs that were done both in the hospital and in the outpatient setting. So currently, as I mentioned before, if an outpatient doctor wants to see the patient's medical record, the patient might have to physically bring the paper from another doctor to the specialty physician, or maybe it's being faxed. But either way, it's not a very efficient, streamlined process. So and also another good example is the ED physician. Many patients present to the emergency room and they might be unconscious. Well, the emergency physician is not able to see, does this patient have any allergies or current medications, and which could be life-threatening unknown. So this HIE in the future will allow both physicians in the emergency room and in the hospital to be able to get the labs and allergies and medication information to get a broader view of the patient. So they have more, they know more, they know the patient better than what they currently do now. So that is local to GBMC facilities. Another improvement that's coming in the future is something called CRISP. It's an encounter notification system where we actually at GBMC will be notified if our ACO patient presents at another hospital facility. So for example, we could know Julie Silva walks into the emergency room at Johns Hopkins University. Well, this patient is currently under our care coordination process. We know, so we can tell Johns Hopkins, we can say, listen, just stabilize them. We'll send our care coordinators out to work with them. So maybe we can avoid a hospitalization for the patient, and thus again reducing our costs and increasing patient quality. So essentially, this HIE is increasing the visibility of the patient for the physician as they're making these life decisions and for their health care. The second technology is the Care Coordination Medical Record, or CCMR. So this medical record is specifically used by the care coordinator themselves. And how it works is information is pulled from the HIE into the care coordinator's medical record. And what's exciting at GBMC is we are, in fact, beta partnering with our vendor, eClinicalWorks, to develop this CCMR specific to care coordination. So we've been having weekly meetings with ECW and our current care coordinators, our nursing staff, and administration here to say, hey, this is what we want to see in the new CCMR. What content do we want? So literally, we're looking at all the paper that they currently use to see what of that should be going into the new CCMR. We're also helping them with the display and aesthetics, both the information. How do they want to see information? When the care coordinator directly logs into the screen, what is most beneficial for them to see a snapshot view of that patient? So that's what we're working on with ECW for the Go Live. And actually, the Go Live is not for a couple months yet, so we're still in the testing phase. But once it goes live, the care coordinator will be able to have much more visibility of the patient care. So the CCMR is, because we're going electronic, the nurse will not have to do so much scanning and transcribing paper records. So we are definitely leaning out that process. We're also improving the care coordinator's workflow from a patient lookup and documentation. So right now, if the care coordinator wants to look up the patient, they actually have to go either to the paper record or into the EMR, which is more designed for a physician's point of view rather than the care coordinators. The care coordinators, if they're specifically talking to the patient about diabetes, they don't want to have to sift through a lot of other information to get to the diabetic information. So having the CCMR specifically for care coordination will streamline this patient lookup and just make it easier for them to be more efficient as they talk to the patient. And also, we are designing, as a care coordinator maybe is interviewing the patient about, are you smoking, and if so, how many times per day? we're building in as many predefined drop-downs and checklists as we can. So it's a simple choosing a word or choosing a phrase or clicking a box so that there's not as much free text. And this will also allow us to be able to run more reports if we want to be able to analyze our patient population. The CCMR will also allow us to be able to track patient progress. So when the care coordinator actually logs into the system, they will be able to see the patient's visit from July, their lab results, next to August lab results. And so they'll be able to very easy and straightforward be able to see different trends in the patient care. Another aspect of the CCMR is increased communication between providers and the care coordinators. So integrated into this is the P2P, the provider-to-provider messaging system. So right now we often see on the charts, as you all probably know from your facilities, is sticky notes or random messages or paper. Well, with this program, the care coordinator can easily type a message into a message box and ping it over to the physician. In fact, they can also attach a summary or any type of note that's in the CCMR. They can attach it so that the physician doesn't then have to go look through the patient records to maybe find that lab result or that discharge summary. It's very easy for this, this type of communication to occur. The last technology that I'll share with you today is the ACO analytics and various reporting tools. So both of these, the ACO analytics is actually through our ECW partner. And we also have in-house reporting tools at GBMC that we're using to analyze our ACO population. But what both of these programs do is they are able to generate reports on the quality and health measures. So why are we investing into these technologies? Well, we want to better manage the care coordination resources. We want to have them focus in on high-risk patients, and we want to be able to tell them these 10 patients, or we want them to be able to have a list. These 10 patients should be the ones that you're following up weekly or monthly, and so we want to definitely streamline this process. And right now, we don't have that. We don't have the standard work for the care coordinators to know who they're targeting across the practices. So what we're doing right now is we've generated reports that list line by line our different patients, listing if they have diabetes, hypertension, and high BMI, to see, okay, which of those patients have maybe all three of those. Maybe those are the ones that we want to focus in on. So we're still going through that process of creating the standard work of where our care coordination resources will be allocated. In the future, we will have this ACO analytics tool that will be able to tell us there's the CMS quality measures. So there are actually 22 CMS quality measures that we have to report on. For like the diabetes has to be less than a certain number. So we'll be able to see through the analytics reporting tool the exact number of Julie Silver's diabetes, so we can zone in right there. And what's interesting, we'll also eventually be able to compare across other ECW users and we can benchmark how we're doing with our ACO quality metrics. And then one last thing for the reporting tools, we're also looking to see the last visit date and also the patient's primary care provider. So we can say, hey, this ACO patient has diabetes and hypertension, but they haven't seen us in a year, and this is their primary care provider. So our care coordinators can then call them, get them in, get them to come see us, so we can provide the care that they need, and hopefully focus on preventative care rather than them getting sick, hospitalized, and then us focusing on them. So we're really trying to be proactive in managing these patients. So the next steps, we are rolling out the HIE and CCMR to the GBHA practices. This will be done probably around November or December. So by the conference time, we'll have I'll be able to report out on it then. So what we're doing right now is we're defining the daily workflows, how the care manager is going to effectively use the CCMR. How are the physicians going to be able to access the HIE, and what's the best way for them to be able to use these tools to make their jobs most efficient. We also need to focus on training and change management. So we realize this is a huge change for physicians and care managers. The physicians are not used to being able to see a complete, or as much as we can, complete view of the patient. They're used to only seeing their specific medical records. So we need to get the word out there that these new technologies are available and they can really impact patient care. In addition, we want to make sure that we are practicing continuous improvement. So we are the data partners right now with eClinicalWorks. And as we're going through the test phase and as we get our pilots in progress and eventually the go live, we want to make sure that continuous feedback is being sent back to our vendors so that they can incorporate it into future upgrades. Also, another major change in our care coordination process that we're going to make is right now there's only one person doing the care coordination role. So this one person is a nurse doing both clinical and non-clinical duties. So what we're doing in the future is we're splitting this up into two separate roles. So we'll have a care manager who is a nurse who will deal with the clinical aspects, the managing of the diabetes, or maybe home visits. I don't know. But we'll have a separate person who is the care coordinator who will work with the patients, call them, hey, you have an appointment tomorrow, just a reminder that you should be going to it, and other administrative tasks as they come up. But we want each person practicing to license. So we want to make sure that the nurse is actually performing clinical duties as much as possible. And then our next step is also defining the high-risk patients and the standard work that's going to go into it. Now, I mentioned before that we might opt to focus in on the AAA patients, the diabetic, hypertension, and high BMI, but maybe we want to focus one of the care coordination resources purely on diabetes patients. So, and then they'll be able to see more patients and reduce the chances of those diabetic patients progressing on to hypertension and high BMI. So really, again, focusing on the preventive measures. So we're still working out how specifically we want to allocate our various resources. So in summary, we are working on major process improvement changes through technology rollouts. The Health Information Exchange will create a broader view of the patient. The ACO Analytics and Reporting tool will allow us to directly monitor the quality measures of our ACO population. And the CCMR, the Care Coordination Medical Record, is the new medical record designed specifically for care coordinators to streamline their workflow. So our overall goal, again, is to facilitate the care management of the ACO population. We are tasked with reducing costs while improving quality. So how would we measure this? Well, in next December, when we have to submit our information, the shared savings aspect of the ACO. So basically, if just for simplicity's sake, if our ACO population was projected to spend $50 million this year on healthcare spending, but we actually reduced it to $40 million. Well, that $10 million difference will be allocated. Some of it will go to our ACO provider network. So we will be able to measure the difference to see our care coordination efforts working, to see if we are reducing the spend. We also can look at the quality measures. We can be monitoring these through our ACO analytics tool to see if we are making progress on the patients that we're targeting. And then from there, go to see, okay, if we're not making progress, what changes can we make before the December reporting period to CMS? So in summary, the current care coordination workflow, our management, our senior leadership has realized that it does need to change if we want to achieve our ultimate goal of improving the patient-centered care, which is why we got which is why we chartered the Greater Baltimore Health Alliance and why we wanted to participate in the ACO. So what can we expect in New Orleans? I'll be giving a status update. We'll be doing these implementations from now until then. So I'll share with you what work redesign was done and what lean and process improvement tools were used. GBMC has fully embraced lean. We just had a boot camp of about 20 people trained up on lean tools. So we're trying to incorporate those into the process redesign. And also, I'm expecting to have some lessons learned. Of course, as you all know, when we're going through these implementations, we really don't know what we don't know. And I'm sure we'll have some good lessons learned that we at GBMC would like to share with you, because there really aren't that many. I think there's around 80 or between 80 and 120 hospitals in the country that are actually doing this Medicare Shared Savings Program, the ACO. So as more facilities join this program, we at GBMC want to be able to share what worked for us, what did not work for us, and hopefully be able to have a conversation so we can also learn from you as we go forward. So with that, I will take any questions you guys have, and thank you very much for having me today. And for questions, if you want to type them into the questions box, we can go from there.
All right. Well, thank you for presenting today, Julie. We did have several questions come through already, and so we'd kind of like to highlight a few of those. One of them, or a couple attendees in particular, we're curious about something you mentioned at the end. You started talking a little bit about the ACO performance metrics and how that eventually ties back to dollars in this whole savings plan. But what are some of the specific performance metrics or measures that are mandated by the ACO?
Specifically, they're looking at diabetes is a big one. There's several quality metrics surrounding diabetes, and I'm not a clinician, so I don't know the exact numbers, but they're really trying to focus on reducing the rate and abundance of diabetes within our ACO population. A lot of them deal with the hypertension, but also in addition to the ACO quality measures, one thing I didn't mention in the presentation is these tools will help with meaningful use dollars as well. So we also, the physicians are incentivized, and they actually get up to around 40 grand of meaningful use dollars, and those are very similar to the ACO metric, quality metrics. And trying to think of some of those, they are being able to use, being able to incorporate the patient really much more into the care process, letting them know here was what was done at your doctor's visit today, being able to give them that sheet of paper saying, this is when your next visit is, these are your current medications. So we're, throughout all the quality measures, we're really trying to basically improve the health and including the patient. And if people want to look at the specific measures, they are very clearly laid out on the CMS website.
Okay, great. We did have a few more clarification or technical type questions about some of the solutions that you're rolling out. So we'll kind of go through a couple of those in case several of the people are a little bit unclear on certain pieces. But you talked a lot about tracking patients and tracking their information across different, across different states and at different entities. So a couple of people are asking, really, what are you tracking by? Are you assigning an ID? Do you have some kind of a master, some type of MRN-like number that transfers across organizations? And then also, how do you manage that tracking?
Okay, yeah. So I actually have a senior systems analyst with me right now, Dolores, and she'll be happy to answer that question for you.
Okay. Hi, my name is Dolores Carter Johnson. I'm a senior systems analyst with the Greater Baltimore Medical Center ambulatory apps team. What we are doing currently is we have from the outpatient ambulatory side, we have patient account numbers. However, the patient account numbers, they sit at the outpatient level. So what we're doing for that initiative is we're tracking in the future goals through our EHX. So what that EHX will do is it will sort of combine or interface or match up the patient account number in ECW to the hospital MRN number, providing the access for that patient to match on maybe 3 different identifiers, and we'll be able to track the information at that level across the board. Does that answer the question?
Yeah, I understood it, so hopefully it does. We had another clarifying question, too, for Julie. Is the CCMR the same thing as the continuity of care document?
No, those are 2 separate things. Right. The CCMR is actually the care coordination medical record, much like the EMR for providers. The CCMR is the medical record for the care coordinators. The continuity of care document, or the CCD, is the actual record that can be sent using, you heard Julie discuss the P2P messaging, or when providers want to send or exchange data with other providers outside of the network or within the network, within the ACO, they can actually send a CCD or medical history with the allergies, current medications for the patient using that nice exchange feature using P2P. So the continuity of care is just basically what it says is a summary of the patient's medical history at a very high level to identify specific measures of that patient's care to give the provider a background of that patient and in further reviewing evaluating that patient's care across the board.
Okay. Now, do patients have any insight into this program that's being put in place? So ultimately, does it really affect the care that they receive? And I guess yes or no, can they opt in or out of the program?
Yes, patients definitely have an insight of this program. We keep a very open relationship with our patients. That is done in multiple ways. So first of all, the patient, we do have a consent for the patient to opt. We are actually an opt-in organization, whereas if the patient is made aware by the providers and the practice staff that if they need to opt out, what that means to opt out. We have a consent form for that. Primarily we see patients, they want to be a part of this. They want their care to be, the information to be distributed across the board because they know, they feel ultimately that the more providers within the healthcare realm that is aware of what their basic health state is, the better off and more efficient the healthcare can be for them. But they do have the option to opt out of that. We also are participants of our own patient portal. It's called My GBMC portal, which patients can either elect to be web-enabled for that portal or not be web-enabled. And through that web portal, they can view their current medications, their labs and diagnostic testing results. They can message their providers directly via the portal. It's been working really well, and currently we have approximately 24,000 patients web-enabled within the outside GBMA ambulatory app practices.
Okay, great. So there was an interesting question a while back about really cross-functionality between the EMR and then the CCMR. So will nurses, I guess, at any level, whether it be outpatient or inpatient, who are documenting in their EMR, will they have to document in 2 different places, or does that information automatically cross over from the EMR to the care coordinator?
Yes, that information, that's the beauty of the EMR and partnering with ECW for the CCMR. That information is interfaced. It is 2 separate logins, 2 separate ECW systems sitting on basically the same database, if you will. However, there are some data elements that are interfaced, whereas though the care coordinator, they can just simply log into their CCMR and be able to view either from the CCMR or EHS level any of the patient data that the provider may want to communicate to the care coordinator and vice versa.
Okay, great. So one of the things I was personally curious about, as well as a couple of the other attendees, is what kind of engagement and buy-in are you getting from the physicians that are involved in this process? Were your physicians involved in the process redesign, and do they know how it's going to affect their daily workflow? And then in addition to that, I mean, how can you really ensure compliance with the use of these new tools?
Yeah, definitely. Our clinicians have been very active in the development of these tools. For the CCMR, as I said, the nurses have been at the weekly meetings helping to design. The HIE, we're actually piloting at several physician practices, so they're giving us feedback about what they like and don't like going forward, so we can hopefully change it by go live. But overall, the clinicians realize that these technologies will immensely help our patient population, and they are fully embracing this at GBMC. It's in the vision, and they really are on board. Even though it is requiring change management, they are on board, and they want to go forward with these technologies.
Okay, great. So another couple of questions we're getting that are more, I guess, quantitative in nature. We've had several come through already asking about how you manage the staffing levels, really, of the care coordinator role. Are you able to give any kind of estimate on how many patients a single care coordinator can handle?
That's a great question. The short answer is no. We don't know yet how many care coordinators we need to manage this ACO population. We have started off by hiring approximately five or six of them in the care manager role. But right now we're trying to figure out how much time each care coordinator would need with a diabetic patient, or if the patient has 3 different chronic conditions, how much time will it take? The other part of that is we're trying to quantify a cost savings of if the care coordinator spends 30 minutes a month with this patient, we're trying to be able to quantify what our cost savings of that is so that we can be able to say, okay, if it's going to save us X amount of money, then that justifies hiring more care coordinators in the future.
All right, great. So we have several people commenting on questions, really just asking for more information and where they can find that, as well as if you publish papers or publish this type of information at all. So I guess, you know, in the next minute or two, if you can give a little bit of information about how people may be able to either get a hold of you or where they can find more info, that would be great. But in addition, one of the last questions we also want to get to is really how does CMS define the success of an ACO, and then does the Greater Baltimore Health Association or Health Alliance differ from that in any way? So there are several groups trying to achieve, you know, these CMS types of programs, but how do you see GMBC being different from those?
So GBMC, we're definitely measuring it the same as Medicare in terms of we're looking at the quality measures and we're looking at the cost, the shared savings difference. But what GBMC is also doing is we're not, all of these programs that we talked about today, are not being just used on our ACO population. They're being used for every patient that that can come in to one of our outpatient facilities or the hospital. So we're really taking a patient view on this, and also we're prepping for the future. Right now, we're only involved with the Medicare shared savings, but it's very possible that commercial payers will also be doing a similar type of ACO shared savings program, and they might have also different quality measures. So we're having discussions with those commercial payers right now to see also what we should be monitoring for when we go live with those. So in terms of follow-up, feel free on your screen. It should have my name and my email address. I also encourage people to look online at CMS's website. Tons of information if you want to read through it. But feel free you're more than welcome to reach out for me. Again, we've been having many discussions with other facilities applying for the shared savings program, or if they've already participated in it or in one of the pilot programs. We love the communication. We love learning from people and sharing what we have. So please feel free to contact me, and I'll definitely, if I don't talk to you then, we'll see you in March.
Thanks for the great segue, because another great way to learn about the ACO process at GBMC is to come to our SHS conference March 1st through 4th at the Sheraton in New Orleans. Again, you can find all the information you need on the conference or the organization at shsconference.org. So with that, we do have a hard cutoff coming up very shortly here. So just a couple of closing remarks. Once again, both the PowerPoint and a recorded version of the presentation will be made available at the webinars page of the SHS website, and we will mail you a link or email you a link in the next 7 to 10 business days. The next webinar is coming up in November. I believe it's November 16th, but again, that information should be on shsconference.org. It will be focusing more on workforce management. Our featured speaker at that webinar will be David Cowan. So on behalf of the SHS Conference Committee, Julie and I would both like to thank our attendees for joining us today. This concludes the webinar. You may now log off.